You're listening to Civic from the San Francisco Public Press. This city, like many places, is facing an overdose crisis. But there is a remedy for overdoses.
In San Francisco, the DOPE project last year had reversed an estimated 8,200 possible overdoses just by distributing Narcan in the hands of people who use drugs.
And there are treatments that help people leave chaotic, destructive drug use behind.
If we use the things that we know works, and we can improve and bend the overdose curve.
Last week, we talked about some of the factors leading us to this overdose crisis. Today, we'll talk about what's being done to help. I'm Laura Wennis, and this is Civic. Before we start the show today, I want to note two things. First, you may have heard on earlier shows that I actually no longer work at the San Francisco Public Press and have left my position as host of Civic. These interviews were ones that I recorded before I left. I just wanted to make sure that they get out there, even if I'm not here anymore. Second, a word of warning. Even though we're talking about solutions today, we'll still touch on trauma, illness, and death. Please take care.
So the first thing to do is to first be able to tell whether someone is just high or they are overdosing.
San Francisco is not alone in experiencing an alarming rise in overdose deaths. A lot of them are due to fentanyl, an extremely powerful synthetic opioid. It's not just fentanyl. A lot of fatal overdoses are the result of multiple substances. But this drug can take people by surprise, either because they weren't expecting it, or they've lost their tolerance, or they didn't know how much they were taking, or even that they were taking it at all. But there is a tool that has been around for a long time that can stop an opioid overdose.
So when you see those two signs, the first, the skin color changing, and the second, the snore gurgle sounds, now you are responding to an overdose.
The drug that does this is called naloxone. Programs to get naloxone into the hands of people who can help stop overdoses have been around for decades. Eliza Wheeler works with one such group, the Remedy Alliance for the People. This organization exists to give harm reduction programs across the country access to naloxone. And here's a key component. The top priority for naloxone distribution is people who use drugs. They're the ones most likely to be in a situation to use it.
Naloxone distribution began in this country in 1996 out of a syringe services program called the Chicago Recovery Alliance. And naloxone's been around since the early 70s.
That's a long time.
Yeah. And was used primarily in hospital settings and by first responders like EMTs until the mid-90s when harm reduction programs began distributing it directly to people who use drugs, who are the most likely people to witness an overdose. So people who are potentially at risk of overdosing are often around other friends or other people who are using drugs. And those people are in the most important and crucial position to reverse those overdoses, especially in a time-limited situation where it's not always possible to get, first responders to come. In, I would say, 2010, that began to change, and more kind of mainstreaming of naloxone distribution began, sort of the inclusion of naloxone distribution into sort of public health practice. There was more research that had been published kind of supporting it as an intervention. More and more states passed laws that allowed for liability protections for providers and distributors of naloxone. And it sort of began to become absorbed into the broader, more mainstream public health system. As that happened, the original kind of radical focus of naloxone distribution that was really about giving people who use drugs access to the tools with which they can protect one another and protect each other in community began getting watered down. And there began to be this focus on absorbing naloxone distribution more into an established medical and criminal justice system. So you see things like pharmacy access pop up, naloxone co-prescription. So when people get a prescription for opioids, they get a prescription for naloxone. Equipping law enforcement, kind of efforts to equip the quote unquote general public with naloxone, civic institutions like libraries or schools. And so as the focus became broader, the original efficacy of naloxone distribution, which really all of the research that has ever been done on naloxone distribution interventions shows that you have to put it in the hands of people who use drugs, or it doesn't really get used in the same proportion that it does if you give it to, a bunch of other broader public institutions and communities.
Maybe a natural question from that for someone who knows next to nothing about this like me is, well, why not just give it to everybody? But you co-wrote a piece for Open Society Foundations last year in which you outlined a supply problem. There is a naloxone shortage. You wrote about how Pfizer was experiencing manufacturing problems and no other manufacturer was willing to sell you affordable naloxone. What was your experience trying to address this shortage and get affordable naloxone?
So last year, in around late April 2021, Pfizer experienced a pretty routine manufacturing supply disruption. This happens quite frequently in pharma manufacturing. It was not naloxone specific. It was not COVID related. It was a problem in the plant. The manufacturing of generic injectables is one of the most sort of highly regulated, and it has to be extremely safe. Everything has to, go perfectly according to plan. And if there's any interruption in the manufacturing, it can cause quite a delay. So the shortage was with one product from one manufacturer. So that was Pfizer's naloxone. So there's plenty of naloxone products on the market. There's other generics, and there's a few branded products. So our organization has always worked with the company that makes this one product. It used to be Hospira, and then they merged with Pfizer in 2017. So we work with Pfizer. And so we provide access to this product to harm reduction programs. We have about just under 120 programs that belong to the Buyers Club in 39 states and DC. And they purchased collectively in 2020, those programs collectively purchased 1.3 million doses of naloxone through the Buyers Club for distribution to people who use drugs. So because we had only ever had this singular relationship with one company, when that company experienced a routine shortage, we had no access to affordable product for all of these harm reduction programs. And so this happened last April, and the shortage is just now resolving. We're just starting to get product again. So there was about 8 months that we had no access to product. So we had to embark on many creative problem-solving strategies.
The Remedy Alliance had to do quite a bit of work to make sure none of the organizations around the country that needed access to naloxone ran out. It required coordinating across groups, taking careful inventory, and redistributing extras. They created a mutual aid network that resulted in some 200,000 doses being shared between groups to prevent any one from running out. And now naloxone is becoming a little more available, which means that it's starting to make sense for more and more people to carry it around. I guess one thing that I would want to talk about is my earlier dumb question about why not just give it to everybody. There's obviously the shortage aspect, but if that eases, why is this not an effective intervention for everybody who lives in a place where there are a lot of overdoses to use or get training in or have access to?
There's a answer to that question that is often, I think, misinterpreted, right? I don't think that any of us that work to ensure that people who use drugs have naloxone are necessarily saying that
no one else can have it.
Right,
yeah.
Right. I think that the drum that we beat is that people who use drugs have to be prioritized in any limited resource setting. So if the city, let's say the city of San Francisco that you operate in, is flush with naloxone, there's just naloxone everywhere. You can get it anywhere. You can get it at the pharmacy. You can get hundreds of doses from the Dope Project. You can get it from every outreach worker. Maybe there'll be vending machines at some point with naloxone. The library has it. That's really one thing. That is a unique situation for this country.
And we're not in that situation right now.
Correct.
Yeah.
And so I think that, many, many places are still under-resourced in terms of naloxone. And if a state, for example, gets money through the feds to support the purchase and distribution of naloxone to the community, if that state is then taking all the naloxone that they've purchased at the state level and then kind of doling it out to a bunch of organizations, and the police get this much and the library gets this much and the harm reduction program gets 100 doses, that is a misallocation of resources. Mm-hmm. So the harm reduction program and any program serving people who use drugs need to have the lion's share of the resources and then work from there.
So yes, you could go to the pharmacy and pick up some naloxone. One thing to note is that you've probably heard naloxone, which is a generic drug name, referred to as Narcan. That's a brand name, although because of a new company buying the rights to the name of an old product, and because of how well-known Narcan is, it's become a widely used term for naloxone, like Kleenex has for facial tissues. What Narcan technically refers to today is a more expensive product packaged in a delivery mechanism, a nasal spray. Naloxone, the generic, is sold in other forms, often as an injectable solution, so you have to pull it from the bottle with a syringe and inject it, although not intravenously, just into the muscle. Generally speaking, naloxone in its various forms is easy to use, especially the nasal spray. Is there anything that concerned bystanders who don't necessarily use drugs can do to be helpful? Are there signs of an overdose that everyone should be able to recognize? Is there an action to take when you're concerned that somebody may be overdosing?
Sure. And any concerned bystander should definitely, if they're interested or willing, visit a pharmacy and pick up a naloxone kit for themselves. You can get nasal naloxone from pharmacies. And I would strongly recommend everyone carrying it. There are resources that are, not visiting your local syringe services program, where those resources are for folks who use drugs in community, but you can go get them from the pharmacy.
And you don't need a prescription?
No.
Huh.
Nope. And sort of quick and dirty naloxone overdose training is really about recognizing the signs of an overdose, which are pretty specific. An opioid related overdose is really about respiratory distress. And so if someone's not breathing, they sort of exhibit signs of lack of oxygen. So their skin color will change. You can, approach a situation if you ever were to see that and, ask if the person's okay, if they can wake up, if they can answer you. You can try doing a sternum rub, which is sort of a rub of the knuckles on the chest. At that point, if you have naloxone and the person is unresponsive and it doesn't look like they're breathing.
Just to be clear, the sternum rub is not some kind of technique to help that just hurts like hell, and if someone doesn't react to it, that's a sign that there's a problem?
Basically, yes.
Okay.
It's just stimulation. It's not super technical.
Yeah.
Some people, feel a little uncomfortable going in and rubbing someone that they don't know's chest with their knuckles. They might pinch.
Yeah, but if the next step is stabbing them with something, I feel like maybe that's the lower bar.
Right. Or spraying something up their nose.
Right.
Either way. It's a little invasive.
Yeah.
The best thing that you can do as a bystander if you are unsure or nervous is to carry naloxone for sure. Definitely. The nasal Narcan is easy to use and it's simple, and it's a great fit for people who are less comfortable with syringes and maybe less likely to see an overdose, and maybe they'll get trained on the injectable and then not need it for years and forget. And so I think the nasal Narcan is a great option for folks who are less immersed in the likelihood of seeing an overdose. And calling 911 if you're unsure of what to do, and then making sure that the person has as much air as they possibly can. So you can make sure people are sitting up or laying down on their side. And there's lots of really great short online overdose response trainings that get into a lot more detail too, that are free.
That's actually what we were playing for you at the beginning of this episode.
After Narcaning them, now you want to perform rescue breathing.
Naloxone, and making sure that people who use drugs have access to it, is really effective at preventing an overdose from killing someone. But longer term, people may want to recover from what's sometimes called chaotic drug use. They may want treatment. Treatment comes in a number of different forms. Dr. Dan Ciccarone, a clinician and a professor at UCSF's Department of Family and Community Medicine, researches the public health aspects of drug use. I asked him, if we think about addiction as an illness, what can treat it?
This is what the current language around addiction is. We don't say people are addicts. In fact, we don't even necessarily like using the term addiction anymore. We're still stuck with it for various reasons. But the diagnosis of somebody who has problematic opioid use, and that means opioid use that's leading to some social, medical, legal problem in their life. The diagnosis is opiate use disorder, or opioid, if you think about all the full class of opioids, including synthetics like fentanyl. Opiate use disorder is a recognized disease entity. If we use a biological model, we use a medical model for opiate use disorder, we then have a mechanism to understand how the brain gets injured by chronic exposure to opioids and how the forces of dependency and tolerance and craving come about. And then we also recognize that if we have a proper diagnosis, then we can also apply a treatment modality to it. So, for example, if we are treating hypertension, right, we know that there's excess blood pressure in the cardiovascular system, and then we can lower that by using medications. If somebody has diabetes, excess blood sugar, we can lower blood sugar either using insulin or other medications. If we recognize that opiate use disorder is a brain disease, and we, through clinical experimentation, find treatments that work for that, then we're working on a disease model. We're working on a biological or medical model of disease. And here's the good news. The good news is that we have medications that work. We have treatments for opiate use disorder. There's 3 evidence-based medications. We have buprenorphine, we have methadone, which has the longest standing track record or history and evidence base. And then we have a new player, which is naltrexone XR or XL, an extended release form of naltrexone. Each of these have advantages and disadvantages, and we leave it up to the treatment system and the doctors in conversation with patients to decide which one is best for an individual patient. Briefly, I'll say that methadone, while it has the best evidence base, is also the most restricted because you can only use it within a methadone clinic, which is federally regulated, highly regulated. So it's powerful, it works, but it has limited ability to treat large populations because you have to create clinics. Clinics are expensive. The reason why methadone works so well is because it's like for like, right? Instead of somebody using an illicit drug on the street with uneven potency, the dangers of injection, here's a medication that people can swallow. It comes in pill and liquid forms. Often at the methadone clinics, it's liquid form. It is a full agonist, which means it takes all the cravings away. It is a substitute. We used to call it substitution therapy. It's still an apt metaphor, if you will. It's a substitution for the powerful opioid, the illicit opioid that somebody was using. Now, this may be controversial because people say, well, you're just trading one drug for another. But you're not. Because while the medications themselves, if you just look at them, just as chemicals, you say, oh, they're both opioids, they're both powerful opioids. That's where the similarities end. Those two things are true, okay? What's different now is you've gone from injection to a normal oral medication. You've gone from uneven potencies to a regulated daily dosage, right? You've gone from the street mentality to a clinical mentality. You've gone from unsupervised and uncoached to having a counselor and a doctor who are managing you. So it's very different, right? Just because it's one opioid matching up with another opioid doesn't make it an undesirable thing because you've gone from an uncontrolled setting to a controlled setting. Buprenorphine can be prescribed by anyone with a prescribing license. Folks such as myself and a number of other addiction medicine professionals have argued that buprenorphine is overregulated. Let's just make it a normal pharmaceutical such as insulin for diabetes. It's not even as dangerous as prescribing insulin for diabetes. So why not, deregulate it, not have any kind of special regulations around it? And that is occurring. We're going from having doctors and prescribers needing 8 hours of training to prescribe buprenorphine to deregulating that and just say, hey, this is a useful medication. If you want to learn how to use it, study on your own and find your own way to competency to using it. And that deregulation effort will even give buprenorphine more power to treat a larger swath of the population. And naltrexone is a blocker. And so it's the one you can only use it if somebody's already had their system cleaned out, if you will, of opioids. So people coming out of criminal justice settings, this may be a useful medication. Folks who really don't like the idea of having an agonist or a partial agonist as treatment and want to have this blocker drug, people by choice, they're going to do well with it. But we have to be careful that we're not going to force the blocker on a large swath of the population, because head-to-head, buprenorphine works better. Naltrexone doesn't do any of that. All it does is block the opioid receptors. So if you were to go and use heroin on top of it, you wouldn't feel it. And so it's kind of a disciplinary drug. It kind of coaches the person to do the right thing. And because it's a monthly injection, that's the extended release form of naltrexone. And so buprenorphine and methadone have higher retention rates. In addition to reducing craving, retention is one of our major goals in the clinical setting.
Not only do some clinicians, advocates, and organizers say that medical treatments are overly regulated, many will also point out that they're underprescribed. A University of Michigan study looked at emergency room visits across the nation from 2019 to 2021 for non-fatal overdoses. It found that just slightly more than 7% of those visits resulted in a prescription for naloxone, which, remember, advocates say is really useful in the hands of people who use drugs so they can prevent overdoses from becoming fatal. And just 8.5% of these visits, where someone had overdosed, led to a prescription for buprenorphine. In San Francisco, several people told me we have a pretty robust treatment system. Nonetheless, according to Dr. Hillary Cunnins, not everyone with opioid use disorder gets treatment. She's with the city's health department, and she has the post of Director of Behavioral Health.
Treatment for somebody with addiction or a substance use disorder is effective. There are a few howevers. One, however, is that we know too few people get into effective treatment for a number of different reasons. One of which is that treatment might not be available. We are lucky in San Francisco that we have some of the most effective forms of treatment for opioid use disorder, in particular for opioid addiction, available. And that most effective treatment scientifically is treatment that includes the use of a medication. The two most effective medications are methadone or another prescribed medication called buprenorphine, which is often known by its brand name, Suboxone. And many parts of the country don't have as available access to those medications as we have in San Francisco. Nonetheless, not everyone takes advantage of getting that treatment for many different reasons. One is part of the disease of addiction is somebody might not be ready for treatment, feels ambivalent about their use, or experience the drug sort of as being part of their life that it's hard to give up. And I'm guessing many of you and your listeners might know people where it's clear that their health would be better were they to stop using drugs. And for the complex reasons that characterizes addiction, they cannot make that move or are unwilling to make that move at that moment in time. And that's part of what we seek to do as healthcare providers, as government, is make the treatment as available as we possibly can, to be there whenever the person is ready, and also to coax the person, work with the person, motivate the person to accept the treatment that we know can be life-saving.
I think one of the top things that comes to mind when people think, oh, well, we need to get folks into treatment is, well, they have to detox. And they have to be somewhere. There has to be a treatment bed for them to detox, have withdrawals, and then from then on stay sober. And I'm not sure that that's an accurate characterization of what treatment means.
I concur that this is what lots of folks think, and I will share with you both from my own many years of clinical experience in taking care of folks coming into treatment, as well as what the scientific literature shows, is that in fact, entering into what we commonly call a detox program, weaning a person that is decreasing their opioid use sort of right now in a day or two from using illicit drugs like heroin or illicit fentanyl to nothing, without ongoing medication support, that strategy, a person will have a very, very high rate of returning to drug use, more than 80%. It is simply not effective.
Wow.
And in fact, in this current moment when fentanyl, which, as you know, is a highly potent opioid that's now very widely available in the illicit drug market, carries a very high rate of overdose. And when a person has stopped using all opioids, their body becomes what's called naive to the substance. So a person who has not been using any opioid at all, if they were to use fentanyl, is very, very vulnerable to overdose. And they are protected from as high a risk of overdose if they are being prescribed and taking either methadone or buprenorphine, which decreases risk of overdose, protects them from a relapse, and improves their health outcomes, including mortality. It decreases their risk of dying. And so this is a matter of some urgency, I think, just to be clear, that these medicines are life-saving and protect people from overdose and keep people alive.
So more than 80% of people who undergo treatment that doesn't include any medication return to the drug use they were seeking treatment for. And if a patient has been abstinent and aren't medicated and then return to drug use, the risk of fatal overdose goes up significantly. Which means what I learned about the availability of medication-based treatment in the city seems like a good thing. So when we talk about what is available in San Francisco, like, what are the options open to people if someone is seeking treatment? When they seek treatment, what might they get?
So what is available in San Francisco is we have several what are called opioid treatment programs. These programs can prescribe either methadone or buprenorphine. And there is capacity in those programs, and folks can enroll readily. So the outpatient treatment I'm talking about with methadone or buprenorphine is not short-term, but it is really long-term care, months to years potentially, depending on the patient, depending on the individual. Other things, just to return to your question, that are available in San Francisco, and is often the first thing people think about when they think about treatment, is residential treatment or treatment that includes staying somewhere overnight. I think what people usually think about is when you're staying somewhere overnight, it comes along with sort of an environment that promotes recovery, that promotes a person stopping drug use, typically involves counseling, both individual and group care, often will involve connection to some of the other things I just mentioned, help with getting jobs or employment or vocational training, help with getting housing or other benefits. And what we know is, again, that the best outcomes, again, just for opioid addiction, this is also true of alcohol addiction, will include the use of a medication. And we're lucky that those two conditions, both alcohol addiction and opioid addiction, we do have a medication that can increase the effectiveness of treatment overall, even without psychosocial counseling, even without the counseling piece. But best outcomes are when those approaches are combined. There are people who feel strongly that they don't want to be on a medication for addiction. Now, I just want to offer that to some extent, I think there's unneeded stigma around the use of medication, that some people feel sort of prejudiced about this, in that they don't feel like this is a genuine approach or route to recovery. And I think it's can sometimes be rooted in sort of misinformation. And I think it can be rooted in, frankly, rightful mistrust of a medical system that has carried out historically and currently racist practices. But I always want to engage people in that conversation and understand what the concerns are about medication and respect them and work with folks no matter their path. And so there are folks who do want to try treatment without medication, and we want to make sure that our systems catch them if there is a relapse and support them in every way we can.
If we zoom out from San Francisco's city services for a bit and look more broadly, the question gets a little bit more complicated. We often hear about getting people into rehab, but what that means can vary a lot, according to Tracy Helton Mitchell. She's an addiction specialist and a person in recovery. She's also the author of several books, including The Big Fix, Hope After Heroin.
A rehab is a place. What's in the place, how much it should cost, how it should be regulated. No one in the United States just seems to have agreement of that. So for a long time, rehabs were a place where a person would go for a set period of time to rehabilitate themselves or to have a period of abstinence from whatever drug or a series of drugs that they were having a problem with. So when I went to rehab in 1998, the typical rehab stay, you could either go to what was a 28-day sort of intensive rehab that usually is like a detox program from alcohol if you had really good insurance. But like for drug rehabs, the typical rehab was around 6 months. In the rehab, you would work, after a period of time, you would go back to work. A lot of times they had, secondary housing that were affiliated with that. So it'd be a whole process of you actually rehabilitating yourself and sort of changing your life. And the dominant sort of structure for a long time was based around 12-step abstinence based recovery. Although a rehab was supposed to be based around a medical system, but there is no set agreement in the United States what a rehab is supposed to be, what the outcomes are supposed to be, what is the treatments they're supposed to be providing. And it's such haphazard care from place to place. I had a friend maybe 3 or 4 years ago that went to rehab. It was $90,000. That's what his insurance paid. And
Oh my God.
when I went to rehab, I was in there for 3.5 months, and I believe the city and county of San Francisco paid $6,000 for me to go to rehab. It was a court mandated rehab with 100 beds. So, he was getting, massages, and they had, a cook, private chef making food, and they took them to yoga, and they had acupuncture, and they had all these things. We had, 12-step meetings, and like basically a counselor going and like pulling a book and saying, this is the curriculum we're going to use today. And they had sort of like different type of things. And you have seen, some players in that realm. The Salvation Army has been running rehabs for a long, long time. You have Hazelton, that's a series of rehabilitation systems. And now you have, a big fight between, the sort of gold standard for opioid treatment is various medications. But a lot of these rehabs are based around abstinence based ideologies where they don't want to let people on these medications come into their facilities. So the United States is in a great state of upheaval now because you have so many people wanting to get into rehabs, and they don't have, first of all, there's not the beds. Second of all, there's not an agreement of what treatment is. There's enormous amount of fraud going on. California is actually one of the big states where there's a lot of, you have whole homeless communities built around people who've been kicked out of rehabilitation facilities, especially in Southern California, where people are brought into the state. They go into these rehabs, they're kicked out or they leave. You have everything from people leaving to go smoke, or they have a relapse. It really depends. And then they end up being homeless, all through the state because they don't even know where they are now. So there's a wide variety of places. So your sort of lower end rehab, they can't afford to have a doctor come in. They might have a doctor come in periodically to check charts and stuff like that. They don't have an LVN even to distribute medications. So those types of rehabs, they don't even want to take people with medical issues or anyone that might have to take any particular types of medications, especially any kind of controlled substance. They don't want to have those people there. So you have those type of rehabs. Then you have all the way up escalating to where they have, a doctor who then does, addiction medicine stuff with the person, who then, they do monitoring, 5 days of monitoring with people with opioid withdrawal, with alcohol withdrawal. I mean, you have like whole sort of medical facilities who run the sort of intensive part at the very beginning, and then they ship you to a more social model after that part is over. So it's really a hodgepodge of places. I mean, I've personally worked with people who've been kicked out. They don't call them kick them out, but they have someone come in, they find out that they're too sick, and they say, we can't work with this person because they can't sit in the chair, they're too sick. Well, why did you admit them to the first place? And now you have to try to find another bed for them. And so the United States is going through a significant crisis that really there's not a lot of coverage around when it comes to rehabs, because as you have homeless crisis, escalating, and you have an overdose crisis escalating at the same time, a lot of people would like to be able to go to one of these facilities. But first, who's paying for them?
Yep.
Second of all, is it safe? Third of all, are they going to accept my loved one with their even mental health issues? Some of them say we can't take people with various mental health issues. which really is against the law, but they say, oh, we don't have the capacity to help that person in this facility. So they're discriminating against someone based on this particular issue, but they say, well, we're not able to serve them. So that really is sort of my wheelhouse, because that's something that I deal with, as a person who just is an advocate, I deal with, every single day. I was just talking to someone the other day. I've got a scholarship to rehab. Where's your scholarship at? Oh, it's to this rehab. The rehab's $50,000, but I don't want to know if I want to go because I'm worried about them kicking me out in the middle of the night. And all these other, some places say, well, you can't smoke, or, they have various rules. Getting kicked out for breaking the rules and putting people out in the middle of the night, is that something that they do? Like, you have to look at all these different things. But some people don't have the ability to do that. They're just going to go to the first place that takes them. And then they find out there's some, quote, rehabs where they're working all day. They're
Yep.
working, and it's basically, unpaid labor. That's what they're calling a rehab.
And then once you're through with rehab, are you then automatically in recovery? For a lot of people, no. But recovery is a difficult thing to define.
Recovery is on a continuum, and recovery means different things to different people. And so the abstinence-based 12-step community has kind of had lock on the word recovery for a long time, but they don't own that. And I don't believe that it's like been a purposeful effort on their part. That's just the way it's kind of worked out. And, years ago, I was a very avid 12-stepper. I was the authority on everything I thought I was, until I wasn't, until I really got into harm reduction. So my type of recovery, abstinence-based recovery, is just one thing. I have some friends who I used to use drugs with. We were homeless and, out on the streets doing all kinds of drugs. A couple of them are nurses now. They drink and they smoke pot. Are they in recovery? One of them says they are. One of them says they're not. What does recovery mean to you? Is recovery being on a medication? Some people say if you're on buprenorphine, commonly known as Suboxone or methadone, oh, that person's not in recovery. Well, how are they not in recovery? They're not shooting drugs. They're not going to jail. They're not going in and out of the hospital. Like, they're doing really well. Like, that's recovery. It's not my place to define what recovery is.
At this point in the conversation, you've probably heard more than one person use the term harm reduction. To explain that, I want to turn to Laura Guzman. She's Senior Director of Capacity Building and Community Mobilization for the National Harm Reduction Coalition.
The way I like to describe it is a social justice movement that really was brought forth in the mid-90s as a result of the neglect of government towards people who were impacted by HIV/AIDS and dying on the streets as a result of their drug use. So harm reduction in that sense really highlights the critical need to save drug users' lives and to really have both their voice and participation in decision making around issues that impact people who use drugs. So in that sense, we always define it as a part of a series of social justice movements in the United States. But the mid-90s were critical for people who use drugs and activists to really start pushing for solutions, practical solutions like syringe exchange, for example, so that people were not dying by sharing syringes. On the other hand, we also describe harm reduction as a set of strategies and principles that minimize the risk or the harms that are caused upon drug use, with a particular lens, in the sense that we see that the war on drugs, in fact, has been successful in targeting Black, Brown, and Indigenous communities historically. So we also see it as a set of strategies to minimize the harms that have been caused by racialized policies in the United States.
So the harm that's being reduced through harm reduction is death and like physical fallout of racist policies. Is that right?
Yes, and I will say reducing harm means also to undo the stigma and to undo the incredible impacts of a violent system that is not just policing and incarceration of people who use drugs, but also systems that really neglect the overall health of people who use drugs. So not just keeping them alive, but actually making sure and allowing them to thrive. And that is why we have this, particular motto, which is we love people who use drugs, because we feel that this is a work that really needs a reframing from every aspect of the systems that we work: healthcare, housing, drug treatment per se, overdose prevention and intervention. What works doesn't mean mandated treatment because not every drug user needs to get mandated treatment. What works means that people have housing, not only as a right, but as a way, as I shared earlier, to actually get their anxiety down, to really address all of the trauma that may have caused the chaotic drug use. A lot of connection between histories of trauma and oppression and chaotic drug use. I think what works means that we know that if we give clean needles, actually, people do not contract HIV, hepatitis C, and endocarditis. We know that if we distribute Narcan, we can reverse overdose death. In San Francisco, the DOPE project last year had reversed, an estimated 8,200 possible overdoses just by distributing Narcan in the hands of people who use drugs. And so what works is all of those different ways in which may increase not only increase the quality of life of people who use drugs, but also honors their expertise in knowing what works and doesn't. A lot of people equate works with treatment, recovery, and being 100% clean, and that does not work for everybody, and that is not what the goal is. The goal is to get our folks to be treated with dignity and respect, to be honored for their expertise, and also to allow them to shine, whether they use drugs or not. I think that is what is very important for us from, a harm reduction framework is to understand that we are seeing increased criminalization with the coming of fentanyl, with the coming of fentanyl as sort of the new fear, the drug to be fearful about, like we do with crack. And we are about to repeat. And when I say criminalization, not just the criminalization of those that are peddling, but also the criminalization of those that are using. We saw in the recent Michael J. Williams case, the idea that if someone sold the drug to someone who overdosed, they should be responsible for their murder. We are repeating the same narratives that didn't work, didn't address the pains of people who use drugs who are poor, didn't address their housing. It's just smoke screens to really not address the systemic conditions that our communities really face. So in that sense, I want to add that this is a new moment to sort of like recommit to harm reduction and to the principles and the practices and the strategies that we know have worked, because the experts in terms of using drugs are people who use drugs, and they have continued to tell us what is needed, and criminalization is not the answer.
Let's take a quick trip to what some might describe as the epicenter of this crisis in the city. Certainly a place where poverty, inequality, chaotic drug use, homelessness, and overdoses are most visible, the Tenderloin. Elgin Rose, director of outreach at the nonprofit Code Tenderloin, and Joelle Yates, a case manager with the same nonprofit, are in the thick of it every day. And they're no strangers to drugs. Elgin starts us off.
So I started this job, I was homeless, and I was going through a lot of stuff, and just letting go of the neighborhood so you can see it from a different lens. It's like what I just went through these past 2.5 years. And so it's like, people don't get it. And you just want to continue to help people. You want to be like, man, because like a bunch of guys that lived by my house, they were just, the definition of bravado years ago. And now it's like they're so defeated by something, and it's almost like babies walking around, just really need help. And that's how I really see it. Like, you just see people that's like so strung out and don't nobody care. And I won't say it to the sense that don't nobody care, but it's hard to help yourself in this neighborhood, let alone help somebody else. And when it's something so powerful like opiates and crystal meth, and things like that, it's just like you want to help somebody because they won't get it without help. You can't do it without help.
Yeah, I've been in the neighborhood for about 12 years now. Now, as a result of my addiction at the time, I almost died. I was fortunate because a lot of people close to me are no longer here. In the middle of regaining my health, I had to separate myself from the neighborhood in mind, separate myself from the harm I was doing to myself. And as I came back to myself, I realized the harm I was doing to myself. I see the harm that people are doing to each other and to themselves. And having been here for so long and how it's welcomed me and the people here have loved me, it's impossible to stay here and not be a factor in this neighborhood and assist someone somehow. I always tell folks, if you starve in the Tenderloin, you choose to. That's that part as far as my gratitude for where I'm at now, years later. I guess it's only natural just, to give back and to support the folks that have supported me, and the folks that come here and may fall in the paths that I walk down.
What helps when someone's really really in it, and just like you said, it's really hard to kind of help yourself, but at the same time, there is help out there. What actually, maybe for yourself or for the people that you've worked with, what really gets somebody out of a bad situation that they're in with opioids?
You got to show the pathway. We got a 4-hour training, right? With a bunch of agencies as we're trying to crack down on what's going on in general. And the missing element that I always keep saying is like, you have to implement the spirit, and the excitement back. You can offer me a room, you can offer me a car, you can offer me work, but if I don't get the connection in all this and see that somebody else has fallen before or somebody actually touched my wound, I use that a lot. You really got to touch the wound of a person and let them know, like, I see that, I see you struggling, and I've been there. It ain't necessarily what's in the bag to help people, but it's that spiritual connection that they can believe that they're living for a purpose or it's doable.
I was telling someone the other day, we're speaking about the opioid crisis, but what we're speaking about really is addiction. Like Elgin said, that spiritual condition, that leads person into lifestyle, and it becomes their preference, their choice, or their incident, if they may fall into opioid or fall into other substance. The root of it, like I said, is that addiction. It's different connections, it's different hooks, different lines that people latch onto that pulls them out or gives them that moment of clarity that allows them to make that choice. For me, I was in the hospital bed and I realized I had forgot about my daughter, that there's somebody that depended on me.
Wow.
And then I asked God, I said, help me to make me a better father. And then he turned around and reminded me of the different programs I'm doing. It was like, you already know, it's time to go do that. For other people, they say it's a connection may get a reminder that somebody cares about them. You may see someone walking around and they ain't bathed for months and they clean themselves with drugs, alcohol. And it may be one person cussing them out saying, man, go take a shower. And there's that moment of clarity. The person didn't realize how bad they stunk. And because somebody actually told them, well, they may go to ask themselves, well, what else have I missed? What else am I not looking at?
How old was your daughter at the time?
This was 5 years ago, so she was 7.
Wow. Oof. And how is that relationship now?
It's beautiful. I mean, I don't want to say there's a good way or a bad way to do addiction.
Right.
I say she never saw me at my worst, but where she sees me now is a lot better.
I want to talk about the role of law enforcement because there are people out there who are selling drugs, but a lot of the ones that are there, I mean, when I was out there, they look really young. Some of them look like kids. And there's a lot of folks out there doing this. They rotate, they're working in shifts. How do you think that the government should respond to this or that law enforcement should respond to this, if you even think that law enforcement is the answer? I should leave that very open. What do you think is the response to the people who are dealing drugs?
Well, it should remain illegal, right? And I was a young person down here doing the same thing. I started off on Market Street in 1988.
Wow.
It's the history to let the young person, it's like, act like, I don't understand that young person right there. Let me stay away, but only to arrest. Now, it was a lot of arrests going on here, and then it just stopped. This is the effect of not allowing police to implement some, we have to have rules, right? But so the conditions been out here so long, it's not that the blame shouldn't just be on them. It should be on the city they should have been implementing programs and teaching right from wrong. It should have been offering more options. So they shouldn't just have been allowed to let the police run the street and just, fix it themselves. It's like organizations like us, like I've been a hustler. Now I'm like, I want so bad to be on the opposite side. So we have to teach what the opposite side is like and show the effect of the neighborhood. And we need all the agencies, as different as they are in the neighborhood, but they need to recognize what's effective. So it's not just arresting, it's also teaching the story and showing people who they affected, and people don't necessarily get it because everybody's on their let me save myself mentality. So yes, they should be here because we need them as well, but it shouldn't just be the only story.
Can you say more about how you teach people the other side and what they can do instead? I mean, if you're making a living or you're whatever it is that you're doing, maybe you're just getting by, maybe you're sending money home, maybe whatever the heck you're doing.
Yeah. You don't it's transferable skills, selling drugs and now selling positivity. It's like, okay, you got to describe what you're offering. You got to describe the effect of it. You got to describe what you can be. Now, I tell people all the time, you can make a living helping people, you know? And so I'm on the path of helping people, and it's sustainable and it feels good. And so I call persons out all the time. Hey, I know you ain't happy because I've been that person that had to stand there 12 hours. And it looks fun from the people that's driving by, like, oh, that guy's out there, they're making money, but the magnitude of this neighborhood is so evil, right? And so it is an emergency to change it. That person, you need to be able to walk up on that young dealer right there and call him out. And like me all the time, I do it all the time. Like, I know you ain't happy, come get this job. And it works. It works. So maybe more of that. We need support when we're on to something. We're on to something right now, and we just have a small team, but we got people, dosing to come to work, really trying, because they see the connection between feeling better, and then you produce better product. You're nicer to the community. So we just need to, say that more.
Mm-hmm. Well, nonprofits are not exactly known for paying well. Is it worth this? Like, obviously, from a non-financial perspective, from a soul perspective, it makes sense to do something better. But can you still make a living? When you tell people about this job, do you say listen, you can still make money, you can still survive?
It's funny you bring that up, because I remember I was sitting in a discussion when you actually do the breakdown of what, the average person will make over the span of time and the risk. They may be making 2/3 of what someone's making working in this field and trying to help people. You break down the loss, all the hours spent outside, their health deterioration, and that's without being arrested. That's without losing what they got to lose.
Mm-hmm.
That's without the stress. That's without the paranoia. All those things. I was out there too one time. I was homeless at the same time. I looked like, I was the man, but homeless. And in a split of 2 seconds, trying to preserve freedom, I lose everything. And there's times that's happened to a number of people.
Mm-hmm.
So it's like I say, it's about that long term. Again, like we're all taught, or hopefully folks can learn where the priority stands. A lot of people want to feel good, look good. But if they really look forward and stuff, all the things can be had just in time.
Code Tenderloin is partnering with a number of other groups in the Tenderloin and beyond, including big medical institutions like UCSF. Their various experts, whether it's those who have lived experience with drug use or those who have worked in a clinic, helps bring a multifaceted approach to this issue. And San Francisco's health department, too, is trying to tackle this from many different sides. I asked Dr. Hillary Cunnins, the city's director of behavioral health, about this concept of destigmatization, avoiding criminalization, treating people with dignity where they're at, harm reduction.
My observation since I've been here in San Francisco is that we are in a place right now where I'm guessing unintentionally finding ourselves to think about harm reduction and treatment as somehow entirely different propositions and approaches. And I think for me and for us at DPH is we see services really on a continuum. To take the term harm reduction really the most broadly is treatment reduces harm. I think the shortcut, though, in the term is often interpreted as a set of services or approaches that don't immediately ask a person to stop using drugs or immediately ask a person to achieve sort of maybe what is the best possible state from a health point of view, which is to use no drugs. Instead, it's a set of approaches that acknowledges, as I sort of was alluding to earlier in the conversation, that lots of folks are not in that moment ready to agree to stop using or even to reduce their use of drugs. And so how do we help them in the moment? How do we engage them, develop a relationship with them, help keep them safe so that we have another chance to work with them to continue to help them move towards healthier places, healthier states of being? And so those sets of practices have come to include things like distributing the overdose reversal medication naloxone, or often called by the brand name Narcan, providing sterile or clean syringes, and so forth. And those approaches have been now in place for a number of years. So we know that they are tested and they work. And we also know from more recent literature, more recent science, that naloxone distribution saves lives. We know this from knowing the number of times that lay people, and particularly people who themselves have addiction or use drugs, are able to reverse overdoses among their friends and loved ones. And we know increasingly from the scientific literature, including some work that I was involved with in New York City, that if we give out naloxone to lay people, and they observe an overdose, they will use naloxone to reverse it and save lives. And so we see this very much part and parcel of how we respond to this current epidemic.
I think it's interesting that you just set up the comparison between treatment and harm reduction. I see what you're saying about them being linked. The contrast that I have heard outlined more frequently is between harm reduction and law enforcement. Like, I think advocates would refer to it as criminalization. And you work in a city government that is also bringing a law enforcement approach to this. Can those two approaches work hand in hand, in your view?
So I think what we're undertaking and undergoing right now, again, as both a country and as a city, is that for many, many years, our predominant kind of governmental investments and our predominant approaches were to try to genuinely interrupt the consequences of drug use by, and we've heard this phrase, arresting our way out of the problem. And the hope and theory was if we could stop drug sales, we would reduce the number of people addicted to drugs and would reduce the consequences of people being addicted to drugs, whether overdose or crime or other ways. Interestingly, methadone maintenance was a program that was initiated by the Nixon administration and by the same government an administration that declared a quote unquote war on drugs. But what was found is that methadone and treatment was what decreased crime. And there have been studies that showed that once methadone maintenance programs, now called opioid treatment programs, were more widely made available, New York City was an early adopter and rapidly scaled up methadone programs in the 80s, was a strategy to interrupt both crime as a crime strategy, as well as a strategy to improve people's health. And so fast forward to where we are now with a lot of sort of, I would say, rhetoric around not wanting to continue this approach. And I think it's very clear that that approach has been destructive by arresting and incarcerating people with addiction. We have not led to their increased ability to seek employment, to get schooling, to get effective treatment, all of which will reduce their subsequent substance use and support their recovery. And so I think that there is no doubt that the sort of pivoting that we're doing now to really focus on making investments, and this has been happening at all levels of government, federal, state, and local, and for sure here in San Francisco, by finding ways to expand our investments in health-oriented approaches. This has got to be a major thrust of the problem, and I think is very much what we're doing here. And we must learn to work together, because where we need support and collaboration with colleagues on the public safety side is to appropriately intervene when and if there are public safety issues. Health approaches certainly can't solve all problems, but I think what we have learned is having health approaches at the center of our solutions, and often in the lead part of the solutions, is critical to successes that we've seen both historically and now.
There is also a major shift happening at the national level. That's at least according to Dr. Dan Ciccarone, the UCSF clinician who researches drug use, who we heard from at the beginning of the show. And this gives him hope.
For the first time in U.S. drug policy history, going back many decades, harm reduction is going to become a pillar of U.S. drug policy. So before this, we've been stuck with these two domains, right? Demand reduction, which usually means treatment, or education, educate youth to say, this is your brain on drugs. It's an egg frying in a frying pan kind of stuff. That's it for demand reduction. And then on the other side, which has had a huge amount of funding, is supply reduction. Arrest people, stop the drugs at the border, crop spraying to further cause barriers to the drug supply. The drug supply pillar has been impressively unsuccessful over many decades. Now, to their credit, they would come along and say, well, if we didn't do it, the situation would be much worse. And it's hard to argue against that. Say, yes, maybe it would be much worse. But let me just tell you the facts on the ground. The facts on the ground is that across all drug classes, all drugs are cheaper and purer than ever, right? And so if one of the goals of reducing supply is to make a drug rarer or to make it more difficult to get by making it more costly, one does not see much evidence to support the billions upon billions upon billions of dollars that we've spent on reducing drug supply. So a new paradigm is needed. And I'm not saying we make drug supply control go away, right? Again, there's that dam effect. Maybe what we've been doing has been keeping it from getting much worse. But reduce criminal penalties, reduce levels of incarceration, because that's clearly not helpful. It only helps people become more dysfunctional in their life as opposed to healthier and wholer. Maybe keep up some levels of interdiction that are evidence-based that seem to work. But let's add 2 more pillars and have a balanced drug policy where we work on demand reduction, that's both education and treatment, and we work on harm reduction. For the first time in American drug policy history, harm reduction is going to be a pillar of the 2022 National Drug Control Policy. I'm proud to say that I was a key figure in making that happen. It's going to be sort of the capstone of my career, is reorienting American drug policy toward harm reduction. The beauty of harm reduction, because it treats people where they're at, because it works on a destigmatized, it works on principles of equity and fairness, because it's inclusive, because it's inviting and trust building, it engages people. And it's the one missing piece in the problem here. If people are running and hiding because they're afraid of being judged, they don't come to your clinic. They don't come to your treatment program, right? Harm reductionists have been engaging them for 20 years now, and it's about time we support the harm reductionists and the harm reduction community to continue that work.
And that's one of the positive takeaways here. We have a crisis on our hands, yes, but we also have treatments that work. Dr. Hillary Cunnins from the health department had this to say about treatment.
When I took care of folks in primary care settings and general medical settings, as well as in specialty addiction medicine or addiction treatment settings, first of all, it's an extraordinary privilege for me as a doctor and gives me the kind of hope and optimism for the success of treatment that I know that not everyone gets to see. And having the chance to work with folks who have gone from really sort of full-blown, very serious addiction to people with jobs and reunited with family and having their own house apartments is extraordinary and gives me great hope that if we use the things that we know works and we can improve and bend the overdose curve.
I'm Laura Wennis, and you've been listening to Civic. Civic is produced by KSFP LP, a project of the San Francisco Public Press. Our team includes producer Liana Wilcox and contributor Mel Baker, who's also programming director for KSFP. Our theme music is by John Dillon. Thanks for listening.